In fact, it looks like we are at the top of the hour, so I want to welcome everyone to the October 2nd Addiction Toxicology Case Conference. I'm Tim Wiegand, and we are presenting from the American College of Medical Toxicology, the American Society of Addiction Medicine, and the Opioid Response Network. Funding for this initiative was made possible from a grant from SAMHSA. The views expressed in this conference material and publications and by the speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. This webinar is accredited for 1 hour of CME if you complete the questionnaire at the end of the webinar or log into the ASAM website. Again, I'm Tim Wiegand, the Director of Toxicology at the University of Rochester Medical Center. My co-moderator is Dr. Gloria Bashevitz, the Medical Director of Strong Recovery and a Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Rochester. We have an excellent group of panelists. I want to thank Dr. Joanne Lace, Attending Physician, Division of Addiction Medicine at Hennepin County Medical Center. Dr. Samya Pandalai, she is addictionologist and medical toxicologist from Banner University Medical Center, Phoenix Addiction Medicine, clinical assistant professor, University of Arizona College of Medicine, Phoenix, Arizona, and Dr. Andrew Stolbach. He's an associate professor of emergency medicine at the Department of Emergency Medicine at Johns Hopkins University School of Medicine. Dr. Ross Sullivan is a director of medical toxicology at the Upstate University Hospital and director of the Upstate Emergency Medicine Opioid Bridge Clinic and medical director of Helio Health. We have no conflicts of interest to disclose, and I will jump right into the first case. This case is titled Walking a Tightrope, Intoxication, and Agitated Delirium. And I'm presenting today to provide some clarification, to really discuss the pathophysiology, and to dispel some of the myths associated with agitated delirium or excited delirium syndrome, as there's certainly a lot in the media regarding this. This case involves a 30-year-old Latinx male who's brought into the ED by police after he was found drinking beer and snorting something from an Altoids tin while in a parked car on a side street in an area of town known for a lot of street-level drug sales and presence. Apparently, police officers pulled up behind the parked car where they observed the male who was in the driver's seat, who was drinking from what appeared to be a beer bottle, and he was ducking down every few moments, holding a straw in his hand. So they pulled up, lights off, officers got out, walked up to the parked car, and observed a Hispanic male bent over, insufflating some white powder off of an open metallic box that turned out to be an Altoid tin. A bottle of Heineken was in a cup holder in the car, so it's clear that he'd been drinking what looked like beer in the Heineken bottle. As officers attempted to open the door, the individual grabbed something wrapped in plastic from under the tin, put them in his mouth, and swallowed them, or appeared to swallow them. He quickly brushed residue off from whatever he was bent over, sniffing from the Altoids tin, and dumped a bottle of beer on the floor of the car. And throughout a scuffle, he was pulled from the car after it was unlocked and out onto the street and placed in handcuffs by police. He's brought into the emergency department for evaluation as officers reported observing him swallowing some white, something in wrapped packets, although he denies this. He states, "They injured my shoulder. I didn't swallow anything." He does admit to doing a few lines. He's very clear about that. He says, "I was doing some lines, I was partying, I did have a beer, but I didn't swallow anything. I wanted an X-ray of my shoulder. They messed it up." He is refusing any labs and monitoring, doesn't want anything done other than the X-ray. The patient's initial heart rate is 120 beats per minute. He has a blood pressure that's 150/94. He has marked mydriasis, or dilated pupils, and is repeatedly sniffing. He's got some nasal discharge, and he's quite loquacious in his response to questions and any interaction. And he just says, "I did a few lines of cocaine. That's why my eyes are dilated. Okay, I did some coke. It was good. They yanked the ground. I want an X-ray. My shoulder's messed up. Okay." And he says it was good coke. The patient has 3 police officers standing next to his gurney, and we had a discussion about concern if he truly swallowed something that it might open up and giving him a benzodiazepine. He refused that and was focused on the Xray. Patient is evaluated by emergency medicine as well as the toxicology addiction team and provider. We have an Xray, which is on the following image. His heart rate has improved. It's gone from 130 to 110. He was anxious, or not really anxious, more tremulous and jittery, but not really anxious, and that's improving. He's no longer sweating, although he continues to talk and comment in near uninterrupted fashion to anyone who listened, both about the cocaine he just sniffed and how it was he was unfairly targeted and profiled. He's not wearing a mask. He refuses to do that, although he's not coughing or acting aggressively. And the image, which they did a shoulder image, so we're able to do an abdominal image, and you can see findings which show an opacity that looks very circular and very clear, almost like a coin or something. But a subsequent image, which I don't have, shows better that it's not just one image, but several small, distinct radiopaque bodies that were wrapped together. So this image came out very clear, but there's actually 5 or 6 pieces of something that are separate. Denies ingestion, refuses intervention. About 2 hours in the ED with slow improvement of symptoms, there's an abrupt commotion coming from his room and police are yelling, he's having a seizure, he's having a seizure. And they are coming out of the room, which is right in front of what we call the racetrack in the ED and the area where the attendings are. His heart rate had shot up to 160s, 170s. He's leaning forward and jerking and looking around, and he's just glistening with sweat. He's profusely diaphoretic. He's held onto by police and nursing who run into the room to keep him in the gurney and from falling out. He was had some restraint with the police, but he is clearly abruptly decompensated and hyperaginergic. He had not allowed an IV, shaking, dripping sweat, and he's breathing very rapidly and deeply. So my question to the panel, what happened? What risks are associated with this, and how do you treat this patient? So let me start with Dr. Stolbach. What do you think happened, and can you comment on what you would do initially with this patient?
Yeah, so this is pretty concerning. He appears to have, some worsening, some pathomimetic toxicity with his, escalating heart rate, his increased blood pressure, the mydriasis that you're describing. He's described as the classic body stuffer, which is somebody who, in the process of getting, arrested or taken in by authorities, just swallows loosely wrapped drugs. So we know that those drugs aren't going to be sealed in there, that they're going to be absorbed pretty well. We know that cocaine has decent PO bioavailability. It's like, about 30% or so. So you're going to absorb some of it, and especially if you have more than a few personal doses, that can add up to a lot. And so, what complicates it is that he might not yet be at a point where, he wants to cooperate with therapy. So I'd like to get him decontaminated, see if he can, take some charcoal and, while I treat the sympathomimetic poisoning with something like benzos, and keep watching him. But I don't know if he's in a spot now that he's going to be able to cooperate with all that, with the oral decontamination.
Yeah, thank you. Great. So he was not in a place where he understood anything. He didn't appear to be having an actual seizure. He was looking around. He had stopped reaching out and trying to get out of bed and was gripping the sides of the gurney really tightly and was just dazed, looking around, had extreme mydriasis, was breathing fast and was shaking, was very warm to the touch. And again, he did not have an IV. So obviously very concerning, and the rapidity to which he had this happen. There wasn't a provider directly in the room with the patient and police, although it was open. So it's not clear if there was some more gradual or ramping up of symptoms, but it seemed to be very, very abrupt. So without an IV and really not able to answer questions or, interact, Dr. Sullivan, what are your thoughts, or how would you treat this patient? Nurses were trying to get an IV at that point, but we did not have an IV, and he was being wheeled from the main part of the ED to the critical care bay at that point.
Yeah, I think, Dr. Stolbach kind of, hit it right in the head there that, I think we need to consider some type of rapid sedation that obviously needs to be not given intravenously since he doesn't have an IV. So my first thoughts would be something like a benzodiazepine intramuscularly.
We've got some.
Yeah, I don't know. Perhaps some intramuscular Versed or something that may work a little bit quicker. There may be, maybe you'll bring it up, there sometimes may be some caution or maybe an idea to also use intramuscular ketamine. But I think in this type of patient, I would be happy to use either, but preferably a benzodiazepine, because there's a lot of things that can be happening, obviously, secondary to this, this agitated delirium the patient is having, including, rhabdomyolysis, hyperthermia, end organ damage or cardiac issues. So I think that we would most likely rapidly sedate the person with some intramuscular medication.
I agree, and my preference would be to go after midazolam for the, rapid onset, and probably with 10 milligrams. Want a fairly big dose very quickly. Dr. Bashevitz, what are your thoughts for this patient?
Well, I just wanted to interrupt first and say that we have a question from the chat that suggests giving him sublingual lorazepam. So maybe you can discuss why or why not sublingual lorazepam.
Yeah, that's an interesting thought. My preference is typically the intramuscular administration, midazolam, the onset, the fairly predictable clinical effects, as well as the shorter duration of action if we would have an overshoot, although I'm not really worried about that here. In fact, we want to get this patient intubated and very quickly sedated, and making sure that he's not acidotic and not hyperthermic, measure core temperature. So I don't have clinical experience with sublingual lorazepam. I'd worry about trying to give this patient something sublingually at the point. He was very confused and agitated with gripping. He wasn't combative at this point, but he was very agitated. And even though police had been at the bedside and he had was under the arrest, there was still some safety questions, concerns, but we really wanted to get this patient sedated very quickly. Samya, do you have any experience with sublingual lorazepam, or do you have any thoughts on this patient and acute care? How about Dr. Lace?
I think that there's a few different options. I'm not sure what the, I logged in a little bit late, so he's in the emergency department, and there's still police presence there. Is that correct?
Yes.
Okay. So yeah, I think starting with a quickly acting benzodiazepine, there are some IM formulations that you can give. There's a lot of formulations that aren't available via IM. Or yeah, I think a sublingual dose of something would also be helpful if he's if you're able to get it in.
Okay, Dr. Pandalai, are you unmuted? Maybe having some issues with your audio.
Okay.
Yes, we have feedback. I think we have two microphones on or speakers. If you could chat in as well, maybe try one more time.
Can you hear me?
Yeah, we have a lot of feedback. I'll have you chat in response and we can read the response as well. I'm gonna move from that slide to the next. So he's abruptly diaphoretic, tachycardic, agitated, stiff, nursing attempts to get keep him at bed, place IVs. So we had already talked a little bit about what happened. So this is, I'm assuming, his open whatever was in the packet, and he has some pathomimetic toxidrome. He has the mydriasis, the tachycardia, he's hypertensive, he's got excitation. And there's a lot of synonyms for this: sympathomimetic, toxidrome, hyperadrenergic, agitated, delirium, confusion, toxic encephalopathy, agitated encephalopathy, excited delirium, which is one of the more severe forms of agitated delirium. We'll talk a little bit about differentiating different types of agitated delirium, but just there's an awful lot of synonyms for this. So acutely, in addition to giving sedatives, what are the primary points of treatment for this? We'll go back to Dr. Stolbach. So beyond getting him sedated and under control, what are you going to do? And then what physiologic changes are occurring in, the severe intoxication, and how would a patient like this die? What would the cascade of events be that would ultimately result in a death in this situation?
Yeah, so this, collection of hyperdynamic vital signs, the blood pressure, the heart rate, but to me, the one that's most urgent to fix and to really target is the temperature. We know that when an individual's temperature is higher than 105, 106 for more than 30 minutes or an hour, that the mortality begins to approach essentially like 100%. Even if it doesn't happen in front of our faces, it'll happen, by the next day. So I think hyperthermia is number one to manage. And so I would want to get, as soon as we could get them sedated enough to tolerate this, and get a temperature and then get continuous, rectal probe temperature management, so that I could do that. And, my first choice would go back to the benzos that we've been talking about before, to stop that muscular contraction, stop the seizures, and go from there. And then, as soon as we get blood, and, I'd also like to make sure he doesn't have, acidosis and rhabdo and, all those kind of associated problems. But temperature, in my mind, is the thing that's going to be the first thing to go up. And it's the first thing that, if it gets out of control, it could kill him. And if we can keep him calm and keep him cool, we can prevent a lot of those other, bad downstream outcomes.
Great, thank you. The title of this case, walking a tightrope, is, the association, I feel, at some point, if we don't get him under control, he is rife with his own compensation. He's breathing deeply, fast, quickly, which makes me concerned that already he's acidotic. That may also just be a central effect, but as the body builds up lactate, the main compensatory mechanism is to hyperventilate. And, in cases where that is taken away, whether, inadvertent through restraint or positioning, patients can sometimes fall off a cliff. Now, that's only in the most severe types of cases where you've had this hyperthermia, acidosis, tissue injury. Sometimes if, this were occurring pre-hospital, and either through just repeated use or binge, or we'll talk a little bit about other causes for severe excited delirium or agitated delirium, the buildup of lactate and the physiology is much more built up in some of the cases, and so really can be precipitous. So getting under control, getting the patient under control is really important. And patients who have adverse outcomes in police detention or described as agitated or acting bizarrely prior to such outcome, occasionally death. What are the common reported causes of agitated or excited delirium? We talked a little bit about drug intoxication, but what else could cause, the severe agitation or excited delirium? Dr. Bashevitz.
So certainly, drug causes are the first things that we think of, especially with all the problems with synthetics and novel psychoactive substances. But there are some psychiatric causes for this, like a very severe excited mania can cause an agitated delirium like this. So it is possible that no drug cause would be found, though in this case, obviously, the fellow was using some sort of drugs in the car. And again, I wanted to just pull us back to the chat for a minute because there are so many suggestions in the chat that we could spend the whole time on this case plus extra time. And I think one of the really important ones is, what is it that made you make the decision that he needed a more aggressive form of control in ED? And he needed an IM right away. And there were also suggestions that we need to especially try and engage with people and not move so aggressively sometimes, because they might be able to be calmed down. So what were you seeing in this person that made you think that you needed to proceed with more aggressive interventions?
Yeah, those are really important questions, really great questions, because, you know, the first approach would be to try and get the patient to relax and to see if they understand instruction, and de-escalate if this were, you know, had any component of behavior, or, you know, we could get, you know, the muscle spasms, he could relax, would really help. And I'd want to explain what was going on and why it was very important to give him some medication. One of the things was he was not understanding. So there was discussion, attempts to try and engage him by saying his name, as well as, do you understand? And the rapidity of onset of his symptoms was extremely concerning. So, you know, when I have a patient that abruptly has this tachycardia, and not just tachycardia, I mean, an isolated abrupt tachycardia could be, you know, from a variety of things that are not, you know, systemic necessarily, but his skin was warm, he was profusely sweating, he was confused. He's got the fingerprints of severe sympathomimetic intoxication, or at least, you know, something that's hyperaginergic. There are other drugs that are not pure sympathomimetic drugs. So I'm worried about vasoconstriction. I'm worried if this is cocaine, that he may have vasospasm in the brain, in the heart, that he may have seizures, that he could have conduction blocks. Sodium channel blockade can occur with severe cocaine intoxication, like local anesthetics cause sodium channel blockade, or tricyclic antidepressants, and that would be a disaster. So I want to be aggressive and get him cooled and calm to save his life. I felt that at this point it was life-threatening and imminently concerning that he would abruptly deteriorate. And, you know, when the patient has these symptoms, there's often a quiescent period, a very brief, he's calmer. They kind of relax, and then the calm before the storm expiring. So I didn't see that here, but I really, really wanted to get control. And I don't, Dr. Sullivan, you have thoughts? Do you agree? You know, I appreciate the comment, though, about trying to engage the patient and de-escalate rather than just abruptly going to medications or to try and sedate individuals. That's very, very important at all levels of engagement.
No, Dr. White, I agree with everything you just said. I think you nailed it perfect. You obviously try to be as less and little invasive as possible. But you know, in this case presentation, he had a very severe, abrupt, you know, change from at least being awake and alert and somewhat oriented to almost none of those things, maybe awake. So, you know, that denotes, I think, a serious acute toxicity that can have a lot of dangerous ramifications. So I agree.
That brings up another thing I wanted to mention. Dr. Stolbach had just taken the lead in a position statement on use of chemical sedation just simply for behavioral control, coming out against it. And maybe you can comment a little bit about that. It was specifically related to ketamine, but Andrew, do you want to comment a little bit about the ACMT position statement?
Yeah, absolutely. Thanks. So the point of our position statement was we had seen media reports of police, law enforcement officers giving or asking EMS to give ketamine, as the article were written, solely for the purpose of behavior control, of somebody that's getting arrested. So we were reading these reports, of people getting, under arrest, appearing agitated, and then police calling EMS over and saying, "Can you give this guy ketamine?" And the EMS sedating them. And so our position that we took, as ACMT, was that we think that ketamine and other forms of sedation should be given by medical professionals for medical purposes only and followed by medical monitoring. So we don't want sedatives being given solely at the behest of law enforcement, solely for a law enforcement purpose. Now things can get complicated, right? Because there's not always this perfect fine line between somebody who's angry, in which case if you're angry and under arrest, you need to be treated like an arrestee, not like a patient, versus somebody with true, severe medical agitation. And if you have a medical cause for your agitation, for example, like a drug overdose, then we would want to treat you with sedatives, like something like benzos or something like ketamine. So it's not always this fine line, and certainly both things can coexist. But getting back to our original position, it's our opinion that we don't want sedation being performed for solely a law enforcement purpose.
Yeah, great. Yeah, thank you. Dr. Bashevitz, did you have any want to follow up with the chat or some additional comments?
Oh, yeah, I was trying to type, but better I should talk. That's a lot easier. So Dr. Razimas mentions that, yes, the literature contains a few discussions of delirious mania, and it's a rare condition if it exists. I agree with that. I was, citing some review articles in which the psychiatric causes, psychiatric alone, are cited, but that is from older literature, and the literature is even before novel psychoactive substances were in existence. So it's very hard to evaluate what were the causes of it. But yes, exhausted mania as a term was cited in older literature. But yes, of course, you should look for medical reasons of this. I also wanted to mention that there are a lot of things, besides trying to engage with the patient, there's a lot of things the staff as a whole can do, such as speaking in calming tones and less bright lighting. A lot of those things are usually advised too. As well, in the case presentation, there's a mention of 3 police officers standing by the bed of this person. That is something that shouldn't be done unless it's absolutely necessary, because many people are put off by seeing uniformed police or even uniformed hospital security folks by their bed. It's better to have the medical professionals out in front. People are generally more trusting of those.
Yeah, those are excellent points. The police very quickly had backed off as the patient was wheeled into the critical care bay. But even prior to that, I think really did there need to be the 3 officers present at the bedside. So one question I had is, I've seen reference to dopamine antagonists in particular antipsychotics and the withdrawal of dopamine antagonists associated with sometimes then decompensation of mood disorder, mania, and that the increase in changes in dopamine are involved in the agitation, excitation, in particular the temperature dysregulation that can occur in the more severe cases. Now, certainly not everyone with an antipsychotic that's stopped is going to develop, severe agitation or excited delirium, but in some cases in vulnerable individuals, or often these cases, they're multifactorial. They're not just simply the drug intoxication, but there may be other components that make an individual vulnerable. So antipsychotic withdrawal and then the right circumstances can also result in agitation that progresses pretty severely. So let's move along. We talked a little bit about this. I've got a slide that simply lists some of the causes of severe agitation that can turn into excited delirium syndrome. Actually, excited delirium syndrome was not even recognized until 2009 as a syndrome, although the physiology that caused this, the same physiology, pharmacology, was well recognized in the 1980s during the crack cocaine epidemic. One of the preliminary panelists that had to back out had Dr. Neil Benowitz, had a lot of experience. Was one of my mentors in fellowship, would describe some of the cases of severe sympathomimetic intoxication from acute cocaine use, whether from body stuffing or just excessive use, binge, and it's similar in whether it's called excited delirium or severe agitation, severe sympathomimetic syndrome. It's the same things that are occurring in the cascade of events. So drug intoxication, stimulants, cocaine, methamphetamine, the beta ketoamphetamines, otherwise known as salts, phencyclidine, which is a dissociative, which also has excitatory neurotransmitter effects in the CNS, synthetic cannabinoids, many of which have more than just CB1 activation. And then I mentioned the withdrawal or discontinuation of antipsychotics, which can result in dopamine dysregulation in individuals. Psychiatric decompensation, which is not as common by itself, but has been cited, as Dr. Racimus, I'm assuming from Hennepin County, and Dr. Bishevitz discussed. And trauma, metabolic, hypoglycemia in the wrong individuals, multifactorial. A lot of these cases, there's acute trauma, sometimes caused during the agitation. Individuals don't realize they're having pain. Some of the drugs are analgesic, or just they don't feel pain, and often there's some psychiatric disturbance at baseline or drug-induced as well. Does anyone have any additional causes? Dr. Lace, anything else you want to add to this list?
I think it's a pretty extensive list. One thing that you might want to add is iatrogenic causes of like neuroleptic malignant syndrome.
Your audio soft, if you can get a little closer to the speaker and mic.
Can you hear me now?
Yes.
Okay. I don't really have a ton to add to this. One thing would be other issues with infectious disease, like encephalitis, other autoimmune encephalitides, neuroleptic malignant syndrome. Maybe I think there's some people in the chat were mentioning giving dantrolene. So thinking about malignant hyperthermia, though I'm not sure that's a very limited setting in which that would be a clinical issue relating to this.
Yeah, no, that's great. The iatrogenic causes encephalitis. The autoimmune or anti-NMD receptor encephalitis, we've been involved in cases that the diagnosis was presumed to be intoxication to begin with, and seizures or agitation, and then seizures presumed to be an ingestion, and subsequently turned out to be not an ingestion, but encephalitis. So very good point. For severe, I've seen also severe precipitated withdrawal, agitation, whether it's somebody giving patient naltrexone and either surreptitious, they don't realize that this is an antagonist and they're very opioid dependent, or adding buprenorphine on top of a substantial dose of full agonist methadone or other opioid. A big dose of buprenorphine precipitated severe withdrawal. I had a case years ago where a patient didn't realize that adding it to heroin would precipitate withdrawal, and he used it as a suicide, that he would take all 30 tablets of the old buprenorphine naloxone tablets and had severe agitation, precipitated withdrawal, that temperature went up, and he was very combative and agitated. So other causes as well. The patient is, we've already talked about approaches to treating him. We use midazolam. I do like ketamine in as well if the benzodiazepines aren't effective, and neuroleptics, although I would prefer a GABAergic agent initially. In this case, the patient was given midazolam, and then the nurses were able to actually establish an IV fairly quickly. We've already talked about other causes of excited delirium, so I'm going to advance the slide. So he's given, should actually be 10 milligrams of midazolam. I have a 5 there. At the same time, an adept nurse was able to obtain a peripheral IV, and propofol was administered, which had been the agent that we wanted to use for sedation. The IM had not begun to take effect, and he is calm, relaxed, and able to be intubated. His temperature, once we got a core temperature, was 40.2. His heart rate's in the 160s, and he started on propofol at 40 mics per kg per minute after a bolus, and he'd been also given rocuronium and etomidate initially during the intubation. In the ICU, dexmedetomidate is added, which is a sympatholytic and alpha-2 agonist, and the propofol had kept him fairly relaxed. The patient did not have any conduction blocks on the monitor. No QRS watch is reassuring. His heart rate had calmed with the sedation, the GABAergic control with propofol. His heart rate decreased the 120s, 110s, and we had placed an NG tube and administered activated charcoal to create a slurry around what we assumed were packets of either cocaine or methamphetamine. Since the patient admitted cocaine, assumed that they were cocaine, but either way, activated charcoal, followed by Go Lightly to do whole bowel irrigation to flush this from his GI tract. And he was admitted into the ICU overnight with his symptoms under control, relaxed, and calm on sedation. The following morning, he had been extubated and was transferred to another unit, an inpatient medicine and psychiatry. And this had occurred on a Friday, and I was surprised that he had been extubated so fast. I would have preferred that they would have continued to Go Lightly until we had clearly seen the packets come out, so didn't have to worry about whether 1 or 2 had opened, but there is still more to be obtained. And he was given Go Lightly to drink, which he did not do. And before I was able to see at the bedside, he'd been cleared and had signed out against medical advice. But it was interesting that he had not been formally under arrest and was able to leave. So there was no packets recovered. He had been warned about the dangers of opening, and he, despite having this occur, he denied that he had still swallowed anything, according to the discharge summary, and was headed home apparently. So this was not a suicide attempt. He was not impaired the following morning. So it was very quick in onset, and I don't have his lab shown, but the initial lab showed a fairly significant anion gap that had resolved overnight, some acidosis with lactate accumulation that had resolved overnight. So my questions to the panel is, how is excited delirium used in current medical nomenclature and in popular culture, and is it appropriately or inappropriately used? And we already talked a little bit about factors that are associated with cases that go wrong. Does anyone have any last comments or questions regarding this case? Dr. Pandalai, to see if your mic is working or if you've been able to chat in. Let's see if we don't have any feedback.
Is there feedback?
We still have feedback, sorry. We'll have you just chat. Dr. Lace, do you have any final comments or questions?
No final comments. You know, like using a term is sort of important to describe something if everybody can agree on it, but basically you have somebody who's altered with a set of vital signs that is in a excited state. So I don't know if like focusing as much on the term that we're using is as helpful.
Yeah, I agree. And I feel that it's also overused. You know, not all agitation is really the most severe form, or, you know, really when using the term excited delirium syndrome, it's really meant for the most severe forms, which it can be life-threatening, hyperthermia, acidosis. One of the questions with some of the recent cases that we've seen in the media is why, you know, wouldn't some people, you know, why are they running, you know, why are they naked, and why, you know, wouldn't the response be to try and get a blanket over somebody, you know, when they're unclothed? And it had come from parents as well as colleagues and counselors in many different scenarios. And, you know, the reason why, you know, I've seen this in the EDS people are hyperthermic. They mentioned initially that cooling occurs through evaporative heat loss through sweating. And a lot of times people don't realize they're desperately trying to cool themselves. And so, you know, clothes come off as individuals try and cool themselves, even when the ambient temperature is very low. Sometimes in decompensated psychiatric conditions, clothes can come off and things. So, but if it's truly excited delirium and the temperature's up, the natural response is to try and, you know, take clothes off. That wasn't occurring here in this case, but in some of the more severe cases that pre-hospital, as they evolve, that can occur. Dr. Sullivan, you have any last comments for this case?
Nope, I have no other comments. Very good case.
Okay, Dr. Stolbach?
No, I
Any
think
other thoughts or
people have made some good points about excited delirium.
Thank you. And Dr. Bashevitz, is any other chat comments, or do you want to add anything to this case?
Nothing to add, but again, the chat comments are very extensive. I hope we're able to save them. And one of the last comments is an opinion that excited delirium should be used as a description of the presentation only, not as a diagnosis. I'm not sure, that's a good point, but I'm not sure how we separate that out and how we might prevent this term being used as a diagnosis if we wanted to.
Right, I agree. And that was one of the reasons to discuss this, just to clarify that there's a lot of different ways to describe the same thing. You know, it's really the important thing is the underlying pathophysiology and in terms of drug intoxication, the pharmacology, and to recognize what is happening and to appropriately treat it, which would start with, you know, trying to talk someone down calmly. And when it gets to the point where you're really walking the cliff's edge, really quick aggressive control is critical to avoid catastrophic outcomes. And you know, that you can see potentially, you know, where a case like this, if the patient didn't have quick access to benzodiazepines, the ability to intubate and get sedation, to make sure cooling occurred, to get fluids, to check the labs, to, you know, that can decompensate fairly quickly. So we could discuss this case for quite a long time. we may have a few minutes at the end yet, but we do have a second case, a shorter case, and this is changing a little bit of direction, and I'm interested in the ways that people respond to abrupt changes in providing patient care in clinical addiction medicine. With COVID-19, we've had to adjust very quickly, starting in March, and some of that was made possible through regulation change and telehealth waivers, and numerous changes to regulation, advocacy, and adept maneuvering. But even during COVID and on the fly, there have been times where additional changes are needed. And I wanted to give an example in Rochester, where an outpatient addiction program is notified by county administrators that there's anticipated to be another protest. There have been numerous protests related to racial, social disparities, a lot of other concerns. And in one of the protests, there have been some vandalism and near the outpatient program. Some windows were broken, cars were vandalized, and there was just at least some notice to the businesses in the area for staff to potentially go home, which was a skeleton crew as well. Some wondering whether in downtown Seattle, Portland, Oregon, New York City, Kenosha, Rochester, in areas that in particular have had protest. Clinical addiction medicine in general may be quickly impacted, and what types of disruption to normal addiction care beyond COVID have occurred related to some of these things, and what methods have used to overcome disruption barriers, in addition to the telemedicine, telehealth. So maybe Dr. Lace here in Minneapolis, have you had, beyond the already adjustments related to COVID, have you had any other adept maneuvering situations that have arisen to change your care on the fly, access to medicine?
Yeah, we had some pharmacies that were damaged in protests, and clinics, and we really had to somewhat adopt some other people's patients who couldn't get their medications from the usual space. We've had to change clinic hours. Some of our staff had to sleep over in the hospital the night before to make sure that they could get to the clinic on time with protests. So we've basically tried to adapt around the changes instead of closing the clinic completely.
That's very interesting. We also had pharmacy disruption in a couple of instances, and patients where there's either a refill or something that's been sent for pickup. Buprenorphine, typically, if I'm prescribing, would be critical for the patient to get, and so having an on-call number or means that the patient can notify providers to change pharmacies really is important. And now in the age of pharmacy restrictions at times, and that can be challenging. So yeah, I appreciated the pharmacy comment, because that was another issue that had arisen. So Dr. Sullivan, any comments?
Yeah, I mean, not so much where I'm in central New York did we have any problems with protests and whatnot, but obviously with COVID, quite a few disruptions. I run a low threshold bridge clinic, and they weren't allowing people in. So, the use of just using the telephone to talk to a person was a huge lift of a burden. So, we use the telephone for a lot in central New York, here in New York State, due to COVID, and without it would be very difficult. So a lot of phone calls.
Yeah, I agree. And a lot of the patients I've been working with don't have access to the smartphone or the internet, at least a substantial percentage. And I'm concerned at some point, if the parity does not continue for phone calls for the New York State and the outpatient setting under OASIS, that going to have some challenges for some of the more vulnerable patients as well, in particular during acute disruptions, but also just in standard, while we continue to have limited on-site access. So any comments, Dr. Bashevitz, from your perspective?
Yeah, so most of our changes were due to COVID, actually, because we were not, our clinic was not in an area where there were a lot of protests. And with COVID, that thing you were mentioning about people not having adequate technology, we have certainly experienced that too. Or sometimes they have adequate technology, but they can't figure out how to use it. So what we've done in a few cases is have one of our peer recovery specialists go out with a clinic iPad and help the person connect to the provider or the counselor here in the addiction treatment program.
That's a great comment. But I think having the mobility, whether it's mobile van or a peer that can bring the technology, or even a separate site that the patient may travel to and access the technology that is appropriately set up for safety, social distancing, and care is critically important. So I've had more than one patient have their child through their use of Zoom, learning for school, show them how to access Zoom or another platform for connection. In some cases, it's very young children showing the grandparent how to access. So it's very interesting to see that, and you leverage support where you can. So any other comments regarding if we had any chat that anyone wants to share a particular experience? I purposefully left some time at the end of the case this today for discussion, but I've been ending with a poem each time. We'll have a few more minutes for chat, but this called Finale came from The Sun, which is a wonderful magazine out of Chapel Hill, and this is the October 2020 issue. It's called Love Poem by Brianne Janet, and I think I'm pronouncing her name right. And it's even now, the old men sit at the corner on their stoop, the three of them on the stairs, one on top of the other, recycled masks hanging from their faces to appease whoever loved them and beg them not to go out into the street. They sit together as they always do, listening to the sirens wail, rubbing the bald spots widening on their skulls. Then they talk like olden days and all the times they didn't die. Online, a meme says, Black people think quarantine means only hang out with people you know. You see the numbers and the pictures of the dead looking in the long lost aunties and cousins. We are dying, they say, faster than others. You can list all of the reasons for this, systemic and ancient as a noose. We're poorer, sicker, and don't have health care. We're essential and expendable. You think of the Black men kicked out of Walmart for wearing surgical masks. You think of the Black men at the corner drinking from a brown paper bag and blowing smoke in the air from their cigarettes. You wish things like were this simple, that we love each other too much and are dying for it. October 2020, The Sun. A good comment from Molly Ivins. So we have about 5 minutes for additional comments and questions. And maybe we can get back to some of the chat that, let me pull up the chat.
There's also a question in the Q&A about excited catatonia, possibly being in the differential, and another question about is it different in different genders? Because a lot of the patients we here presented have been male, but have you ever seen cases of this type of excitation in women?
Of the catatonia, the excited catatonia?
No, the two are separate questions. Presentation in women, would that be any different?
Well, that's a good question. good question. I don't have the experience with excited catatonia. Often NMS is confused with malignant catatonia, or not necessarily confused. They're both in the differential diagnosis. NMS was mentioned earlier, neuroleptic malignant syndrome. In my experience, typically neuroleptic malignant syndrome would advance very slowly, and classically kind of the gradual stiffness, the temperature gradually coming up. Often when it's recognized that patients are very sick. Catatonia, different mechanism, but stiffness, and in the malignant catatonia, the temperature can certainly be a problem, but they present less acutely from my experience. And maybe, you, Dr. Bishevitz, would have more experience with the catatonia. The question about women that I have, stimulant use is more common in males, methamphetamine, but also increasingly common just across the board. Dr. Pandalai had a comment about methamphetamine use on the rise in Phoenix, and actually methamphetamine use is on the rise across the United States. There's very interesting research showing the frequency is increased across the board, and the frequency in particular when fentanyl is also encountered has risen dramatically. And one recent study looking at about 1 million urine screens over a 10-year period from different healthcare settings across the United States, the frequency that methamphetamine and fentanyl were co-identified in the urine screen was as common as up to 40% of the time when methamphetamine was found. Fentanyl was also found as of 2019, 2020, compared to about 5% of the time just 10 years ago. So stimulant use is increasing, methamphetamine use is increasing, and the concomitant use with fentanyl in particular, this is sometimes referred to as the fourth wave of the opioid epidemic, the methamphetamine and cocaine along with fentanyl. Let's see, there was a couple of comments that Dr. Pandalai had commented. Nora Volkot Nida made a comment recently that when hospitals are pushed to capacity, there's an added danger of a person with substance use disorder being deprioritized for care if they assuming present with COVID symptoms. As a community, we have to see these patients as being just as worthy as care of anyone else with chronic medical issues, and I completely agree. I do think that there are ways that we can particularly offer support if there's surges to the hospital and the emergency departments. There are ambulatory protocols for alcohol withdrawal, for opioid initiation and maintenance that you at one point may have said we can initiate in an ED or hospital setting, or treat the alcohol withdrawal in particular. If not, the more severe forms, ambulatory support is certainly feasible. And what can be done through ambulatory telemedicine, telehealth is all in flux depending on the acuity. At downstate earlier in March, there was limited access to ED and hospital beds, and detoxes in many places were used to treat and support patients with COVID that had taken space and priority away from the treatment of substance use disorder. So people had to really get creative and offer unique ways of connection. So a couple more messages. I appreciate the comments regarding the poem. I thought that was a powerful piece as well. Thank you. And I think we're running to the end of the time. We've got about 1 to 2 minutes left. Anything else that any of the panelists want to add before we end for the hour? Dr. Lace?
Nothing to add.
Dr. Sullivan?
Nope. Hope everybody has a nice and safe weekend.
Dr. Stolbach?
No, nothing to add. Thanks for including me.
And Dr. Pandalai? Thank you. So true, stigma. I appreciate your comments in the chat. I'll assume that. Thank you. And then Dr. Bishevitz, anything you want to close with?
No, just thanks everyone for coming. And this was a great discussion.
Excellent. So thank you for joining us. This is recorded, and we will also have follow-up. Please check both the ACMT or ASAM websites and the Opioid Response Network. We have some summary that will be prepared and pearls sent out, as we had done for the first case in particular last week regarding the designer benzodiazepines. This will again occur on the first Friday in November, so please look to join us on November 6th, and then in December 4th, and on the second Friday in January 8th. So I know I've already had some questions. We're not having this on January 1st. So thank you all, and sign in November. Have a great rest of your Friday.